So we'll start off with DKA, just a little definition there. So it's an acute life-threatening complication of diabetes characterized by a biochemical triad of high blood sugars, ketones in the blood, and acidosis. Just keeping in mind that you can get DKA without hyperglycemia, which we'll come on to in a bit as well. Classically affects type 1 diabetics, but it can affect type 2 diabetes as well. Cool, so we'll start a bit about the physiology of DKA. So as we mentioned, these three things are sort of the main drivers, the main bits we look out for that make for diagnosis and decide on our treatment as well. So it starts off with an insulin deficiency. In most cases, this will be an absolute insulin deficiency. So people with type 1 diabetes, that could be a new diagnosis, or people who have missed their doses, or people who are on their normal insulin doses and have an increased requirement, for example, in like an acute infection. Sorry, I'm having trouble with that one. Oh, yeah. So after that, you get an imbalance in the hormones, which leads to a number of different things. So you get a high serum glucose, production of ketones, and the ketones then lead to an acidosis. So we're going to go through each one of these three things separately, just so it make a bit more sense, because I think it helps with your management and understanding the disease process. So we'll start with hyperglycemia. So first of all, as we already mentioned, you need to have an insulin deficiency to begin with. Usually it'll be an absolute insulin deficiency, such as patients with type 1 diabetes, either a new diagnosis, missing their insulin, or having an increased requirement for insulin, such as an acute illness. You can get it from people with type 2 diabetes as well, but this is a lot less common. So if we think of insulin acting like a key for the cell, it's a bit cliche, but I think it helps. So if there's no insulin, key can't open the door, and the glucose can't enter the cell. So as a result of the deficiency of the glucose entering the cell, the body essentially thinks it's starving, so it thinks it hasn't got any glucose, so it tries to create more energy, and it does this by boosting up the hormones such as growth hormone, cortisol, glucagon, and adrenaline. These are collectively referred to as your counter-regulating hormones, so the hormones that do the opposite stuff to insulin, so generally increase your glucose levels. So those hormones lead to a few different things. So your liver begins to produce more glucose, referred to as gluconeogenesis. You also get breakdown of glycogen stores, which is referred to as glycogenolysis. And then you also get breakdown of fat into free fatty acids as well, which we'll come on to in a minute. So these two things primarily lead to a high glucose, which can't enter the cell, so you get the high serum glucose. So that explains the first abnormality of that triad we mentioned earlier. And then this is just to sort of demonstrate that in a different way. So insulin, you have a deficiency of insulin, get upregulation of these counter-regulatory hormones, and they vastly outweigh the insulin, and you end up with a hyperglycemia. So we'll move on to the ketonaemia now, so ketones in the blood. So that hormone imbalance we mentioned earlier leads to the breakdown of fatty acids. And this is essentially to try and get an alternative source of energy, because the one that we usually use, which is glucose entering the cell, isn't working anymore. And then, so as the liver tries to use these for an alternative energy source, it does it through a process called beta oxidation. And that's just to try and produce acetyl-CoA, so we'll come back to that in a second. And byproduct of this process is you produce ketone bodies as you do this. So your three main ones are acetone, beta-hydroxybutyrate, and acetoacetates. So acetone is what gives you that sort of characteristic pear drop smell of the breath in patients with DKA. Beta-hydroxybutyrate is the main one involved in DKA, the main one that causes acidosis. And it's also the one you can measure with the point of care test as well, the finger prick test. Cool. So as we mentioned, so this is what usually happens. So you have glucose, enters the cell, undergoes glycolysis, and you get pyruvate. Pyruvate then forms acetyl-CoA and enters the Krebs cycle. But because insulin's deficient, we can't get glucose to enter the cell, and this doesn't happen. So what happens instead? Fat gets broken down into free fatty acids to produce acetyl-CoA to produce energy. It doesn't enter the Krebs cycle, does it in a different way, but that's not important. And as a byproduct, you get these things, which are ketones bodies, and so you get ketones in the blood. So now I've described how you get a high blood sugar and how you get ketones in the blood. We're going to move on to describe how you get an acidosis. So the ketones themselves are weak acids. Initially, that's compensated for by the body. So the body can compensate for this and prevent acidosis. And it does this by increasing things like bicarbonate, which are buffers, bind to the acids and neutralize them. That could only go so far, however, and once it's overwhelmed, the pH starts to drop and you get an acidosis. You might see some manifestations of the body trying to compensate. So as we mentioned, the kidney will try and increase bicarbonate to compensate for this, and the respiratory system will try and increase ventilation to reduce the partial pressure of carbon dioxide in the blood. And that leads to like a characteristic sort of pattern of breathing. So I was wondering if anyone could pop in the chat what that is, if they can remember what that is. Yeah, brilliant. So zinc smells respiration, and that's exactly what I was after. So another effect of these ketones is it leads to nausea and vomiting and abdominal pain, which you characteristically see in DKA. And it also makes your hydration status a lot worse and might contribute to some of the electrolyte abnormalities we see. So we've briefly gone over the three of these. So it begins with a high insulin, glucose can't enter the cell, begin to produce energy through a different method, break down fats. As a product of this, we get ketones. Ketones overwhelm the buffering process and we get the acidosis. So there's a couple of other things as well to be aware of in the pathophysiology, which will help your guidance. So we'll go through those quickly. So as you might already know, people with DKA have a massive fluid deficit. So I think if you're about a 70 kg male, you could have about 7 or 8 litres in deficit. So they're really dehydrated by the time they reach hospital. So as we mentioned, we get a high serum glucose, and the kidney can only absorb so much glucose. So once it's overwhelmed, it starts weeing out all the glucose, and that pulls with it all the water. So you get an osmotic diuresis. And once you've got a high serum glucose as well, you also get a high osmolality in the blood, which also contributes to the dehydration and pulls water out of the cells. So that just says what we've just been over. And the high osmolality can also cause hypernatremia. As a result, you also get a big potassium deficit, and we'll go over that in a second. But essentially, potassium moves out of the cells in exchange for hydrogen ions. Because the blood's acidotic from the DKA process, that's accelerated. So you get hydrogen ions trying to move into the cells and potassium moving out into the blood. But because you've got a high urinary excretion, so you've got a diuresis going on as well. So all that potassium gets weed out. And despite this, you can still get a normal serum potassium. So even if someone's potassium is normal on a blood gas or a UNE, they've still got a massive body deficit, and it'll drop really quickly once you start giving insulin as well. So I think it's something like, for a 70 kg male, it could be like 140 millimole deficit, which is quite a lot when you consider there's only 40 millimole per litre would be the sort of standard concentration of potassium chloride we'd use in hospital. And then as a result of the dehydration and increased osmolality, that can cause like brain cells to change their osmolality, which can eventually lead to decreased consciousness and coma. So this is just to go over what I meant by the potassium being low, even though you can have a normal serum level. So first off, as you probably already know, potassium is mainly an intracellular ion, so concentration within a cell is much higher than outside the cell and in the blood. So what happens in DKA is you get an acidosis in the blood. The body tries to compensate for this by shifting the hydrogen ions into the cells. And as it does this, it exchanges potassium the other way, so potassium enters the blood. But as we already mentioned, you get a massive diuresis and all that potassium gets weeded out. So you end up with a big deficit of potassium because it's all shifted out of the cells where it's usually located into the blood and excreted in the urine. But you can still have a normal serum level, so on your blood test it can be normal. Cool, so we talked a bit about the pathophysiology and what actually happens in DKA. So we're going to go over the common causes. So there's 3 main causes for DKA. So a new diagnosis, so the first diagnosis of DKA, you usually see it in sort of children and young adults. That accounts for about 20% of the cases. So missed doses, so if someone with known type 1 diabetes misses their insulin doses. And if there's an infection or any other sort of acute illness that puts more demand on the body and makes it need more insulin, that can also precipitate DKA as well. There are some more sort of rarer causes as well, things like alcohol, other stressful events like an MI or trauma, and some medications as well, but these are the 3 main ones. Cool, so we'll go a bit over the presentation of DKA. So could you just put in the chat any signs or symptoms you can think of associated with DKA? Cool, so there's loads of stuff on there. So yeah, things like pair drop breath, brilliant, abdo pain, polyuria, increased respiratory rate, yeah, associated with that Kussmaul's respiration we mentioned earlier. Decreased consciousness, yeah, which is just a result of that increased osmolality in the brain cells changing their osmolality as well. Brilliant, hypotension as well, that's great. Cool. So much of what we've already said really, so increased thirst, so polydipsia, polyuria, which is increased urine output, just generally feeling weak, nausea and vomiting and abdo pain, which you already mentioned is likely due to the ketones, and drowsiness and decreased consciousness, which can happen from the brain cells losing their normal osmolality and normal gradient across the cell. I mentioned the pair drop breath from acetone, one of the ketones that's produced, Kussmaul respiration to try and breathe off more carbon dioxide, and abdominal tenderness and reduced GCS as well you might get. Cool. So some of the things you might get that hint towards precipitants and underlying causes of DKA, things like missed insulin doses in the histories. You might get symptoms of infection such as like fever, dysuria, cough, shortness of breath, and chest pain, because we mentioned MI could be a cause as well. So just thinking about once you've got a clear-cut history, trying to find out what the precipitant is as well. So now we've gone over the presentation, we'll go over how we assess these patients. So obviously going to use an A to E assessment as you would with anyone else who's acutely unwell. We won't go over sort of how to do an A to E assessment or anything like that today. We're just going to mention some of the things you might think about in someone with DKA. So you want to make sure the airway is secure, which you might intervene if the GCS is lower for persistently vomiting and not protecting their airway. On B, you might identify the source of infection. You're going to hopefully see like Kussmaul's respiration and a raised respiratory rate. On C, they're probably going to be tachycardic, can be hypertensive as well, in which case you'd start your resuscitation there. These patients need good IV access and take your bloods at the same time as well. Moving on to D, so you need to assess their GCS, because we already mentioned you can get reduced consciousness, abdo tenderness, and again trying to find a source for infection. E, look to see if they're pyrexic, maybe exposing them to see if there's any rashes or any other signs of infection anyway. Cool, so we're going to move on to investigations now. So the first one is a venous blood gas. There's no real need to do an ABG in these patients, according to the guidelines anyway, unless there's another reason for it, such as respiratory failure. And that'll give you most of the stuff you need. So you'll get the pH straight away, you'll get the glucose straight away. So the only other thing you need is the ketones. We can usually do this by a point of care ketone measurement, so like a capillary measurement. I mean, you're going to do your other bloods anyway, so you're going to do a U&E just to get the lab glucose, which is important because if it's exceptionally high, it'll just read high on the VBG of a BM machine rather than give you an actual value. And the electrolytes are going to be a bit more accurate from the lab as well. The other ones are really just to help identify any underlying causes like infections or MI. As we mentioned, we're going to look for the precipitants, so things like an ECG, looking for any arrhythmias, looking for an MI. You can get arrhythmias from the electrolyte disturbances as well. I'm going to send some urine off, do chest X-ray, and do the rest as you deem appropriate from what you find in your initial assessment. And don't forget to do a pregnancy test in females of an appropriate age as well. Your sort of glucose and insulin metabolism is different when you're pregnant as well. So I think there's an increased risk of DKA when you are pregnant. And obviously these sort of investigations looking for precipitating cause aren't going to delay your initial management. So you need to get on and treat these patients and then you can worry about that afterwards. Cool, so the diagnosis for DKA. It's quite simple. It's the three things we've been over already. So a high glucose, over 11, or known diabetes, an increased level of ketones, even more than 3, on a point of care test or a lab test, or ++ on a urinary dip, and also a pH below 7.3 or a bicarb below 15. As we previously mentioned, though, you can get DKA with normal blood glucose, which we'll come on to in a minute. And then, pardon me, these are just some things to be aware of as well. So these are the cutoffs for severe DKA. Might be worth like knowing a few of these for your exams and stuff. Something like a pH is probably one worth remembering. And if you've got hyperglycaemia already, it's going to be pretty severe. But have a look through that in your own time. We won't read all of that now. Cool. So onto the two sort of abnormal presentations we've already hinted at. So one's ketosis prone type 2 diabetes. So this is when you've got type 2 diabetes, but you can still get DKA. And then the other one being euglycemic DKA. So that's when you've got DKA, but the blood glucose levels are normal or only slightly high. So as we mentioned, some patients with type 2 diabetes can get DKA. This is more common in patients of Afro-Caribbean ethnicity. The other one is euglycemic DKA. So that's DKA with normal or slightly elevated glucose. These patients actually have worse outcomes and increased risk of mortality. And it happens most commonly in two main groups. So that's patients with poor glycogen stores. So people like people with liver disease or chronic malnourishment, and also patients taking SLG2 inhibitors for their type 2 diabetes. So they're just two things to be aware of, but if you get tested on those, I'll be pretty surprised. Great stuff. So we'll move on to the management now. So these are just your main goals of management. So you're going to correct that dehydration from the diuresis, clear the ketones because that's what causes the acidosis, reduce the glucose to a normal level to help with the osmolality, and correct any electrolyte abnormalities that you might discover along the way, treat the precipitating cause, and try and prevent this from happening again. So most of the treatment I'm going to mention now just comes pretty much directly from this, which is like the main guideline for DKA management in adults. We'll mention DKA management in children in a second as well, but we're not going to go through all of that. So let's start off with fluids. So as with any other patient, if they're hypotensive when you're AT assessment, then you need to start resuscitation fluids. So that'll be something like a 500 ml bolus over 15 to 20 minutes of a crystalloid, something like Hartmann's or normal saline. You can repeat this if you need to. If BP is not improving, then you need to get some serum input, so you might need vasopressors or other sort of interventions. And obviously, as always, be careful in patients with risk factors for being overloaded, things like heart failure and renal failure. So once you've resuscitated the patient, if you need to, you start on the fluids to correct that massive deficit that we mentioned earlier. So you might need to add potassium in as well, because as we mentioned, patients are depleted of potassium. And once you start insulin, that's going to drop straight away as well. So this table here gives you an overview of the sort of fluids you'd use in someone with DKA. So you'd start off with a litre without any potassium, then you'd add a potassium depending on the serum level. And those are initially over 1 hour, and then over time it gradually gets longer and longer as well. So you should correct most of the deficit by sort of 24 hours or so. Obviously you need to carry on assessing the patient, seeing if they're overloaded, if they can take more fluid on board, keeping a close eye on the sodium and other parameters as well. So we'll go into a bit more detail about potassium. So similar to sort of glucose, once you give IV insulin, the potassium will start entering the cells as well. So even if someone's got a normal potassium or a slightly high potassium when they come in, it's probably going to drop quite quickly. As we mentioned, patients have a massive deficit of potassium. So we add potassium into saline. So potassium chloride is added to saline to prevent severe hyperglycaemia. Need to monitor this quite closely. So you're going to do it every 15 to 30 minutes for the first couple of hours and then gradually decrease. So don't include any potassium chloride for your first litre or for your resuscitation fluids. And that's because patients should be well hydrated before you start giving insulin. So you need to give that litre and then start your insulin. So whether or not you need to add potassium is basically dictated by the serum potassium level. So if it's over 5.5, you're not going to add any more potassium because you don't want to make someone hyperkalemic, because that's obviously just as dangerous as it being severely low. So that table sort of just says this. So you adjust according to the serum level. Don't want to overshoot, don't want to undershoot either. And if it gets really low, so less than 3.5, then you want to get some senior input, because they might need high concentrations of potassium chloride given, then you can give through a peripheral intravenous cannula, so you might need a central line, or be given higher concentrations through 2 drips, but need continuous cardiac monitoring because of the risks involved. So this is just a picture of like bag of saline with 40 millimoles per litre. So they come pre-mixed in the UK at least. So it's just to be aware what they sort of look like. So move on to the insulin now. So we've talked about the fluids and potassium replacement. So patients will start on a fixed rate insulin infusion. So it's not a sliding scale. Needs to give patients insulin regardless of the glucose. So what happens if the patients become hypoglycemic, when you continue with insulin and start adding in dextrose. So this is the dose that you generally start on. So it's 0.1 unit per kilo per hour. So for example, if someone's 70 kilos, you're going to start them on 7 units per hour. If someone's on say a basal bolus regime and they're on long-acting insulin normally, then you just continue this. You don't have to stop this. However, apart from this, you shouldn't be using sort of subcut insulin for treating DKA. It should be all IV apart from their long-acting insulin. So you can make up like the infusion, mix in something like Act Rapid or another rapid-acting insulin with 50 mils of saline. So as we mentioned, if the glucose goes low, you don't stop the insulin, you just add in glucose to stop hyperglycemia. And the insulin might be adjusted according to the ketones. I wouldn't worry too much about this because it's sort of later on as well, and probably going to be dictated by a senior. So you're aiming for a drop of 0.5 millimoles per litre per hour initially. And if it's not reaching that, you're going to increase it by 1 unit per hour. Cool, so these are just some of the, we mentioned what we need to monitor already really, so it's just common sense of the things that are to range need close monitoring on. And these are some of the targets. I won't worry too much about these because it's going to be in like any DKA bundle or whatever you're using anyway, but it's just something to be aware of. And this is when you're going to continue your insulin infusion until you reach these targets. So I'm going to briefly touch on DKA in children, which is similar, but the fluid's a bit different. So can anyone sort of mention in the chat why we're worried about giving too much fluids to children with DKA? What's the main complication we're worried about? Yeah, so loads of people have put it in already, so good. So yeah, as we mentioned, so as people have put in the chat, we're worried about cerebral edema in kids. I don't think it's fully understood how it works, but basically they think if we flood with too much fluids too quickly, then brain tissue can swell from change in osmolality, which can cause coma, etc. So the fluids are going to be different. So you need to calculate it according to severity of illness and also the weight of the patient. And you're also going to add on the maintenance fluids. So this is probably the document to look at for management of DKA in kids. So we'll quickly touch on the fluids. I'm not going to go through all of this, but basically you give either your initial resuscitation or an IV infusion, then you work out how much of a requirement there is, and that's dictated by the severity. You also need to find out what their maintenance fluids are. So you need to replace that deficit over 48 hours, but you don't include anything you give for resuscitation, basically. So you can have a look at that for your own time, or just have a look at these BSPED guidelines, because that probably explains it much better than I did. Cool, so that's everything for DKA. I'm not sure if there's any questions on the slide, but I'll have a quick look. So someone's asked, do you need all three to be completed, all three criteria to diagnose DKA? Generally, yes, but as we mentioned, you can get DKA with normal glucose. But if you've got high ketones and an acidosis and it fits the clinical picture, then I think I'd imagine that's enough. I'm not too sure. Someone's asked what sort of IV fluids would be most suitable for DKA, normal saline or ringers. I'm not too sure. I think salines and the guidelines I looked at. For initial resuscitation, I don't think it'd matter either way. But if you're going to be adding in potassium chloride anyway, then you need to use that anyway. So it'll be the saline with potassium chloride, I suppose. Hopefully that helps. So we'll move on to HHS.
Sorry, Paddy, we had one in the chat. I don't know if you saw it.
Oh, no, sorry. What was it?
So that someone's asking if patients can continue to eat.
I'm not sure is my answer. I mean, most patients would be reasonably ill when they've got DKA, so I'd imagine most patients wouldn't be eating. I'd probably edge towards no, to be honest, just because we're an insulin infusion, and you're going to be controlling that glucose quite tightly anyway, but I'm not too sure. Yeah, someone said they can, but they wouldn't want to. That was what I was getting at as well. But I don't know if anyone else has got anything to add to that. Cool. And someone's asked, what's the time of the insulin infusion after the 1 litre saline or parallel to the fluid bolus? So the fluid bolus would be for your resuscitation. Or do they mean that initial 1 litre fluid? Yeah, so you give a litre of fluid and then you start the insulin generally. That's what I've understood from it anyway. Cool, so we'll move on to HHS if that's all right. So this is another diabetic emergency, but this is mainly seen in type 2 diabetes. So you might have heard it being referred to as HONC before, which is hyperglycemic, hyperosmolar, non-ketoacidotic coma. They sort of changed the name because basically not everyone's in a coma and it's a bit misleading. Have a quick look at the chart. So someone said, can you give subcut insulin and DKA? So you can give the long-acting subcut insulin and DKA, but otherwise you'd give IV. And that's only if they're on that already. So you're continuing their long-acting insulin rather than sort of starting them on long-acting insulin, if that makes sense. So HHS, sorry. So characterized the 3 main things again. So a bit different to DKA, but some similarities. So you can have a hyperglycemia, but it'll be a lot higher in HHS, often above 30, easily above 40 in some cases. And your osmolalities increase from that high glucose, like we mentioned earlier in DKA, but you don't get a significant ketosis, so you don't get loads of ketones being produced. You can get a little bit being produced, but nowhere near as much as in DKA, and that's because you'll still have a bit of insulin, so that'll turn off the process that leads to ketosis, but it won't be enough insulin to drive that glucose into the cell. Mortality for HHS is a lot higher as well. So if you think of a typical patient that gets HHS, it's an elderly patient with lots of comorbidities. So that puts them at an increased risk to begin with. I think the mortality is like 15 to 20%, so it's really high. It also has a gradual onset as well, so by the time they present to hospital, there's also a lot of abnormalities and a big deficit in fluids. So as we already mentioned, it's a bit different to DKA, so it requires different management, but you can get an overlap between the two as well, but we won't go too much into that. We'll try and keep it simple. So I'll move on to the pathophysiology of HHS. So in this case, you have a relative lack of insulin, either not producing too much, or it's not effective because you've got insulin resistance in the rest of the body, so it's not working. Again, you get an increase in these counter-regulatory hormones such as growth hormone and cortisol that we mentioned earlier. This leads to a high serum glucose, get the same osmotic diuresis, which both lead to a high osmolality. As we mentioned before, you still have enough insulin to stop ketosis happening, so from ketones being produced, but not enough to shift shift glucose into the cell, sorry. So hopefully that makes sense. So similar to DKA, you get some precipitants, so there's something that usually triggers it. So it's usually a patient with either known or unknown type 2 diabetes and then something else on top. So infections, starting someone on high-dose steroids, MI, vomiting, stroke, or it can just be someone with poor control of their diabetes. However, when I was looking on Patient UK, there was absolutely loads, so I wouldn't worry too much about all these. Just keep in mind that there is usually a precipitant to it. So we'll go on to the presentation. So unlike DKA, which usually presents over a couple of days, it's a bit more insidious. It takes a bit longer to present. So it takes sort of days to weeks generally, maybe even towards the end of that week's sort of period, almost a month. Much of the symptoms are quite similar. So polyuria, polydipsia, nausea and vomiting, weakness and generally feeling ill. Seizures are quite common, seen up to 25%, and 10% of patients will be comatose. So despite the name HONK being changed, you still do get about 10% of people being comatose on presentation. Some of the signs you might get, so it might look clinically dehydrated, might be hypertensive, reduced GCS. Patients can get focal neurology, which is probably important to remember because it can mimic stroke and sort of could be one of those stroke mimics that catches you out. And as we mentioned, there might be features of whatever's precipitated the HHS episode in that patient. So this is what the sort of, not so much a diagnostic criteria, there's no clear sort of criteria for it, but this is sort of what you need to be present before you can say someone's probably got HHS. So we need to be dehydrated and have a hypovolemia. The blood glucose needs to be really high, but without significant ketones. So they can have a little bit of ketones, but it's got to be less than 3, so less than the cutoff of DKA. And there's no significant acidosis, so you can have a slight reduction in your pH, but it shouldn't be below 7.3. And you also got to have a high serum osmolality, so you can get that from sending off bloods to the lab, or I think it can be calculated in some way. Yeah, so the main things being no real acidosis and ketones are still pretty low. And as we mentioned, you can get an overlap between DKA and HHS, so that picture can be a bit muddy. So some of the investigations you might do for HHS. So as with any other sort of acutely unwell patient, you're going to do an A to E approach. These patients are often sort of comatose or reduced GCS, elderly to begin with, things like dementia are more common. So it's going to be really hard to identify your precipitant from history alone. So you might take a bit of a shotgun approach, unfortunately, and see what comes back. So you're going to do ketones, of course, to get the diagnosis because we need to be less than 3. You're going to do your glucose, and you're going to do your VBG, LFT, routine bloods, really, add-on and amylase, CK, ECG as well, because we've mentioned some cardiac stuffs can be precipitants, urine dip and culture, chest X-ray, and consider a CT if GCS is low as a focal neurology, because you want to rule out differentials as well, because realistically, if someone's got focal neurology, HHS isn't going to be at the top of your list. It's probably going to be something you figure out later on. Cool. So we'll talk a bit about the management quickly. So these patients are generally pretty unwell, as we already mentioned. You get mortality of about 15 to 20%. And they've got significant comorbidities to begin with before we even had this acute episode. So most patients are going to need HD level care, so sort of level 2 level care, because it's going to be quite demanding on nursing staff as well, with all the monitoring and watching the fluids, etc. So you've got some quite similar goals to DKA, really. So you want to get rid of that deficit, correct any electrolyte abnormalities there might be, aim for normal glucose, reduce the osmolality, but importantly in HHS, you want to reduce complications as well. So that reduced osmolality, which we mentioned earlier, the high osmolality we mentioned earlier, can lead to complications such as stroke, DVT, PE, MI, that sort of stuff. So most patients will need low molecular weight heparin. So we'll start off with the IV fluids. So as we mentioned, patients have an absolutely massive deficit. So if you think there's at least a 7-litre deficit in someone with DKA, that's 70 kilos. In HHS, it's going to be even higher, so it's absolutely huge. This fluid deficit needs to be corrected really slowly, though, so you need to do it over a number of days. So you're initially going to start with a litre of normal saline, given over an hour, and also always, if you need to, you give resuscitation fluids. And as we mentioned, once you've given that first litre, you need to correct this deficit really slowly, or you're at risk of causing some complications. So some of those complications are things like you can cause cerebral edema, you can cause something called central pontine myelinosis, where your brainstem essentially stops working. You can cause hyponatremia as well. These patients are often going to have risk factors for becoming overloaded as well. So you can have lots of patients with things like heart failure and renal impairment. So you don't want to flood them with loads of fluids either. So patients need to be catheterized to guide with fluid management. So you're going to aim for about 2 litres positive in the first 6 hours. And then, as we mentioned, you need to do that really slowly afterwards. So we'll move on to insulin and controlling BMs, so blood glucose. So short story is generally don't need insulin in this condition in HHS. Are some scenarios where you might need it, but I wouldn't worry too much about this because it's essentially like a specialist decision whether or not to start insulin. And we're aiming for a BM of 10 to 15. So once it drops below 14, you should probably start thinking about adding in dextrose to these fluids to prevent hypoglycemia. Again, similar to DKA, we're going to monitor the electrolytes really closely. If you do start insulin, then potassium's going to drop. And your cutoffs when you're going to add potassium chloride to your normal saline are similar to as we were in DKA. So these are your targets, what you're going to aim for sort of treatment resolution, I suppose. But I wouldn't worry too much about these as well. They're just useful to have and useful to be aware of. So as we mentioned, you can get some nasty sort of complications from HHS. So that includes things like MI, DVT or PE, stroke. So the hypovolemia, hyperviscosity, and just generally being in a severe state of illness, but strain on the heart could precipitate MI, might make pre-existing sort of coronary artery disease worse. And that can also, the hyperviscosity can also manifest in strokes as well. So as a result, most patients will be put on low molecular weight heparin unless there's any sort of real contraindication to that. And then the other ones we mentioned are things like cerebral edema and central pontine myelinolysis. And that can happen from rapid correction of the hyperglycemia and the osmolality. And it just causes big fluid shifts within the CNS. So we can reduce this risk by not correcting glucose too quickly, hence one of the reasons why we don't give insulin, and also correcting the fluids slowly. So that's everything I've got to say about HHS. We can move on to adrenal insufficiency, if that's all right, unless there's any questions. So someone's asking, is regular insulin not available? Is it possible to substitute with short-acting subcut? I assume that's for DKA. My answer would be, I'm not too sure. I don't know, maybe if you're desperate. How long should we give these fluids? So that's going to be dictated by your targets and whether or not you're reaching that sort of the goals you're aiming for. So once everything's corrected, obviously you don't need to flood them with any more fluids. So have a quick look on the slide. Brilliant. So if it's all right, we'll carry on. So next thing we're going to talk about is an acute adrenal insufficiency or an Addisonian crisis. So it's a life-threatening condition that happens, does what it says on the tin, basically, due to an acute insufficiency of adrenal hormones. So we're not going to go too much into sort of Addison's disease and adrenal insufficiency and all the causes and diagnosis and stuff, but essentially it's usually a 50-50 split between patients who are already known to have adrenal insufficiency, and then another 50% that have undiagnosed Addison's or other cause of adrenal insufficiency, and this is their first presentation to the ED with it. So there's lots of different causes of adrenal insufficiency, with Addison's disease only being one of them. We're not going to go into too much detail, but it's two sort of main groups. So you've got your primary causes. So that's anything that affects the adrenal glands directly. So Addison's disease, which is like an autoimmune condition. You can get hemorrhage, infections, or they might be removed surgically. And your secondary causes are things like things that affect other areas of the HPA axis, so the other things like head trauma or brain surgery, which might damage the hypothalamus, or things might affect the pituitary as well. Cool. So the essentially what happens is you don't get enough of the supply of the steroids from the adrenal glands to meet the demand the body needs. And the main one you're concerned about in this sort of state is cortisol. So cortisol is thought to be the main one involved. Aldosterone is involved a bit as well, but not to the same extent. So either it can be a first presentation and someone's just reached that point of critical illness and they present to the ED, or it can be that someone's known to have Addison's disease or adrenal insufficiency, particularly regular steroids, but they get something on top of that, like an acute illness or a stressful event, which leads to an increased demand of their cortisol. So once again, the adrenal glands won't be able to meet that demand. So you're giving exogenous hormones, so you're giving them tablets, you're giving them hydrocortisone and fludrocortisone, but it won't be enough to meet that demand that the body needs. So some of the stuff that can cause that are things like infections, surgery, intense exercise, and apparently like even emotional stress can do it as well. And one of the other really common causes to be aware of are patients on long-term steroids and high-dose steroids. So if they're stopped quickly, essentially the adrenal glands stop producing steroids, so they're not used to producing their own steroids. You stop taking the tablets, the steroid tablets, and they go into sort of Addisonian crisis. Some other causes that could, some of the like rarer causes, things like hemorrhage. So if you hemorrhage into your adrenal glands or infections and stuff like that, but I won't worry too much about those. So I'll talk a bit about the pathophysiology. So as we mentioned before, the main hormone that we're deficient in, that we're worried about, is a cortisol deficiency. So cortisol is the main stress hormone, which you probably already know. So it causes things like vasoconstriction, it's got anti-inflammatory properties, helps with producing glucose. And then to a lesser extent, aldosterone is involved as well. So in health, it usually causes retention of sodium, your intravascular volume increases, and in exchange, you get excretion of potassium. And then we can sort of couple these things together, and it sort of accounts for some characteristic things we see in the disease. So low cortisol leads to a low glucose. A low aldosterone leads to a low sodium. and high potassium, because as we mentioned, it usually causes potassium reabsorption and sodium reabsorption and potassium excretion, and both together contribute to hypertension or hypervolemia. So we'll move on to the presentation. A few people could just put some stuff in the chat about what sort of features we might see in someone with an added sodium crisis or an acute adrenal insufficiency. Yeah, cool. So there's some good stuff in there already. So things like abdominal pain, nausea and vomiting, reduced GCS. Cool, yeah, so it's, again, quite non-specific really, which might make your diagnosis quite difficult. So just generally feeling unwell, fatigue, nausea and vomiting, abdo pain, fever, muscle cramps. And then later on, you might get things like a coma or decreased consciousness or confusion. And some of the signs you might get are things like hypertension. Patients might be shocked when they arrive. You might notice some hyperpigmentation if they've got Addison's disease, and might have a pyrexia from an underlying cause. So some of the investigations we're going to do, so it's going to be your routine investigations really, but the things to be aware of are sodium, which will usually be low from that low aldosterone, and then your potassium. In textbooks, it'll often say it's through the roof or in your exam questions, but it can often be normal or only slightly increased, so it can be a lot more subtle. And then you can have a low serum glucose as well. Serum ACTH or serum cortisol might be done straight away, but you don't need to wait for those to come back for the diagnosis. So once you've got that sort of clinical picture, you can start giving the steroids. It sort of helps confirm the diagnosis, might help the diagnosis later on, because it's obviously the picture gets a bit more difficult once you've given the patient steroids. But yeah, it's just something to be aware of. And then, as we mentioned, we're going to investigate for the underlying cause. So this star here just highlights like the classical sort of exam question, what the abnormalities would be. So you get a high potassium, a low sodium, and a low glucose. But as we mentioned, potassium can be normal. Cool, so we'll move on to the management. So can anyone tell me the main sort of steroid we give in Addison's? What we give to try and treat it? Yeah, good. So a few people said hydrocortisone, which is absolutely correct. And then someone said hydrocortisone only, which is good. So yeah, hydrocortisone. Usually give it IV, but you can give it IM, I believe. So your dose is usually 100 milligrams for adults, and you don't need to give fludrocortisone in an acute adrenal insufficiency. And that's because at that massive dose of hydrocortisone, it's going to have mineralocorticoid properties anyway, so it's going to do what fludrocortisone would do at that dose. And then once you've given that first dose, they're probably going to need ongoing replacement until you've sort of settled the acute illness. You can start them with oral therapy. So that would be something like an infusion or a dose every 6 hours, but I wouldn't worry too much about that because that's sort of a bit higher up and a bit further on. So the other thing you're going to need to manage in these patients with their hypotension, so they're going to often be shocked when they get to you. So you're going to give the IV fluid boluses as needed, as we mentioned earlier. If they're not responding, you get senior input. One thing to note is patients can be quite hard to manage if they're very hypertensive, and that's because they have a poor response to vasopressors. And that's because essentially cortisol usually increases your sort of reactivity to catecholamines. So if your cortisol is low, you're not going to react to catecholamines as you usually would, and that includes things like noradrenaline, which is one of your main vasopressors. So they're often going to need 2 or 3 litres in the first couple of hours, so they do need quite a lot of fluids. And you're going to add in dextrose early because, as we mentioned, they are hyperglycemic in most cases. And as with DKA and HHS, you need really good close monitoring of those electrolytes, especially after you give that high dose steroid, because it could change everything a bit. And you're going to act accordingly. So if you need to give potassium, you're going to give potassium. Patients can have a hypernatremia, especially once you start giving saline to them. However, once you start giving the hydrocortisone, they'll have that sort of mineralocorticoid effect. So what aldosterone usually does do, hydrocortisone will start to do, and that should start to reduce. So it's unlikely that you're going to need to give like 0.5% saline or anything like that to try and reduce the hypernatremia. Hopefully that makes sense. And as with the other ones, consider continuous cardiac monitoring as well if your electrolytes are off. And as with the other ones, we're going to try and find the underlying cause. And we're going to sort of manage it going onwards, so endocrinologist referral, etc. So we're getting on, I think it's been about 40 minutes or so. So we're on thyroid storm or thyrotoxic crisis. I don't know if anyone's got anything to ask, or should we crack on? So someone's asked, are the MI, DVT and stroke complications of the HHS itself? And that's yeah. So you get a high osmolality. So your osmolality in the blood's really high, and you get a diuresis. So the blood's really sort of thick and gloopy, and you're more susceptible to having clots. And you can get a stroke from, an MI from that, or from the increased strain on the heart as well. It's like a type 2 MI. Yeah. So we'll move on to thyroid storm and thyrotoxic crisis. So it's an acute life-threatening presentation of hypothyroidism that leads to organ dysfunction. So it's just a really severe case of hypothyroidism, essentially. It usually happens to patients with known hypothyroidism, but it can be their first presentation, and mortality is really high. So it's about 30%, which I didn't realise until today. So some of the causes, so you need two things to happen really to get a thyrotoxic crisis or a thyroid storm. And the first one being you need to be hypothyroid for some reason. And that can either be that you're known to have hypothyroidism. Graves' disease is the most common in this process, but you can get other things like adenoma or a toxic multinodular goiter, or someone's hypothyroid, but they just didn't know about it. So they've got undiagnosed hypothyroidism. So the first thing's having hypothyroidism, and the second thing is having some sort of precipitant again, which seems to be the theme of all these diseases. So an infection, stopping their medications, trauma can happen after surgery, that sort of stuff. It's unclear exactly what switches someone from just being hypothyroid to having this storm sort of acute organ failure picture. So it might be the rate of change in the thyroid hormone rather than the level itself. The level itself isn't thought to be sort of proportional to severity or anything like that. It might be a case of that change in thyroid just making your sort of sympathetic nervous system much more sensitive than usual. But it's not exactly clear. The presentation now, and it's really simple because it's literally just hypothyroidism on steroids. So can anyone mention some of the symptoms of hypothyroidism, symptoms and signs? So look at the chart. Yeah, so there's stuff in there already, like hypertension, pyrexia, diarrhea, tachycardia, palpitations, lack of tolerance to warmth, seizures. Cool. So yeah, much of what you've already mentioned. So patient's going to have a tachycardia. It's going to be quite high. You can get arrhythmias as well. You can get cardiac failure as a result of the tachycardia and the arrhythmia. Patients can get something called a high output cardiac failure as well. So even though the cardiac output's really good, they're pumping out loads of blood, it just can't meet the demands of the body because the thyroid hormone's so high, the metabolism's through the roof, and the blood just can't meet the demand. You can get hyperpyrexia as well, so it's common for patients to be really, really hot. That obviously leads to dehydration from the sweat. Nausea, vomiting, diarrhea, someone mentioned, really common again. And then change in mental state as well. So confusion or delirium or psychosis is quite common. So some of the investigations which we're going to mention, so thyroid function tests, your T3 and T4 are going to be high, and your TSH are going to be low as well. But as we mentioned, the level of these doesn't really matter too much, as long as they are high and it fits the clinical picture, then that's probably enough to start treatment. If someone's obviously really unwell and you suspect a thyroid storm, you should start treatment without waiting for these to come back. So you might have signs of decompensation, so things like an AKI, abnormal white LFTs, electrolyte imbalances, etc. ECG might show arrhythmia, and you can do an ABG as well, because these patients can have acid-base imbalances as well. And once again, we're going to investigate for the underlying cause once they're stable. So we're going to go over some of the management, so general supportive measures, things like resuscitating the patient, cooling the patient as well. They're going to have massive deficits from their sweat, so they're going to need a lot of fluid generally. So you can give things like paracetamol as well. Patients might need sedating if they're psychotic or very agitated from the disease process. And you can give a beta blocker to help with that higher heart rate, so something like propranolol. And this is sort of your more specific treatment for the disease itself. So you're going to give an anti-thyroid drug, so either carbimazole or propylthiouracil. So I think this one's preferred, the propylthiouracil, because it helps prevent conversion of thyroid hormone peripherally in the blood as well. So that's the first thing you're going to do. You're going to give an anti-thyroid drug. And then you can give like an iodine solution as well, but you only give that once the first bit's been given. Otherwise, you're just giving a lot of iodine that will be converted into thyroid hormone. So once you inhibit the thyroid hormone, you then give this iodine solution. Patients are also given hydrocortisone as well, because they have a relative aldosterone deficiency. So they don't have enough aldosterone for what's going on. So they give some hydrocortisone. And if this all this fails, and your last resort is plasma exchange or just taking the thyroid hormone out, but as you can imagine, these patients are going to be really unstable, and surgery is probably going to be the last thing you're going to want to do. So on to our second to last one. I know we're getting on a bit now, so I'll try and whiz through, and we can answer some questions at the end, hopefully. So myxedema coma. So it's just a rare complication of low thyroid function, so hyperthyroidism, and you lose the adaptive sort of mechanism to normal homeostasis, and it's got a really high mortality, so even higher. So thyroid storm is about 30%, and this can be up to 60%. So as I just said, seen in patients with long-standing hyperthyroidism, this can obviously be undiagnosed again, or unknown, and it could be a first presentation. So the patient's physiology adapts over time to try and compensate for that low thyroid hormone. So you get things like the blood vessels vasoconstricting peripherally to keep the body warm centrally, and things like that. And then what happens is you get some sort of event that tips that over the edge, and we can no longer compensate for that low thyroid level. So that can be loads of different things. So things like medications, infections, hypothermia, hyperglycemia, or surgery. So as we said, you get a low T4 from a chronic hypothyroidism, and you get some sort of event that just tips them over the edge as well. So this fella's back. So some of the symptoms are really similar to hypothyroidism, just to a higher extent. So unlike thyroid storm, it is a thyroid on steroids. This is just like a really sleepy one. So can someone tell me like some of the symptoms or signs you'd get with hypothyroidism? Yeah, so things like constipations, dry skin, putting weight on, cold, that sort of stuff. So as we mentioned, you're going to get your classic hypothyroidism symptoms. Altered mental state as well is really common in most patients, and some things I looked at said it has to be present to make the diagnosis. So it could be low mood, confusion, coma, psychosis, all sorts of stuff. Hypothermia is also present as well, and that could be really severe, so it can be less than sort of 35 degrees C. Hypotension as well, and a bradycardia. So some of the bloods, so TSH will be elevated in most cases. It can be normal, however, if there's a central cause of a hypothyroidism, so a pituitary cause. And then you're obviously going to have a T3 and T4, so the thyroid hormones are going to be really low. A low sodium is really common. Anemia is common. LFTs can be raised, and a CK can be raised as well. And you can get a low glucose secondary to the decreased metabolism. And you can do an ABG as well, because you can get type 2 respiratory failure because patients just aren't breathing adequately and you get a hypoventilation. And some other stuff you're going to do, look for precipitants, so chest x-ray. You can also get effusions from the disease itself. ECG, you can get a bradycardia and other sort of changes associated with hypothyroidism. Serial cortisone might be done as well, and that's just because hypothyroidism and adrenal insufficiency can often coexist from poor pituitary function, so often test for it. If they think one's present, both can be present. Screen for an infection as well. That's just an ECG to show like an example of what you might see. So really low voltage, so small spikes, and a really big bradycardia as well. And you've also got some non-specific T-wave changes there as well. Cool. So we'll go over the management quickly. So supportive measures, things like patients might need ventilation, whether invasively or non-invasively, IV fluids, correcting electrolytes. It's really important when you warm these patients, you do it slowly. So when you warm the patients, their peripheral vasculature dilates. As we mentioned, one of the adaptive mechanisms for having a low thyroid hormone is that those blood vessels usually constrict. So once they dilate, after you warm them up, their blood pressure can drop and become hypotensive really quickly. And then on to like specific measures. So I think they're sort of a bit contentious and there's no real evidence to direct it because it's such a rare disorder. But you can get things like so we usually go for things like replacing the thyroid hormone, usually give it IVs. I think GI absorption is really poor. And depending on where you look, it says you give T3 or T4, but generally most things say T4. Broad spec antibiotics are usually given off the bat because infection is a common precipitant, and these patients again also need hydrocortisone, and that's because it's safer to sort of assume that they've got hypopituitarism, because I assume that's quite a common cause for this, and then you come in for adrenal insufficiency at the same time rather than waiting and finding out. So I think that's been about an hour. I can go over pheochromocytoma quickly if people want to. I don't know what the committee members think or what they want me to do.
Committee's happy with you to carry on.
Yeah, is that all right?
People in the chat are saying that too. Yeah, that's
cool,
fine.
No problem. So if anyone wants to dip early or whatever, that's perfectly fine. I'll just have a quick look at the slider as well. So there's nothing else in there, but that's fine. Cool, so we'll go over this quickly. When I was looking over this, I think the more you look into it, the more complex it gets. So I tried to keep it aimed at sort of acute presentations and sort of acute stuff you can get. And it's only a short summary as well, because I didn't want to go into it too much. So there are rare sort of neuroendocrine tumor that leads to production of catecholamines, and that can lead to a number of different emergency presentations. So we'll go over sort of a bit more about that. And different sort of tumors can secrete a different amount of different catecholamines and stuff. So the presentation can be really varied. how much they secrete and when they secrete and stuff can be sporadic. So I think like things like pressure, so if you press on where the tumour is or whether that can release it. And these are really commonly missed as well. So some of the stuff said that, some of the stuff I was reading earlier today said that about 50% of cases aren't diagnosed until post-mortem studies, basically. So to begin with, what are they? What are pheochromocytomas? So as we mentioned, they're neuroendocrine tumours that arise from a type of cell called chromaffin cells. And they're usually in the adrenal medulla, so the medulla area of the adrenal gland, but you can get them elsewhere in the body as well. And this leads to an increased amount of catecholamines in the blood, so things like adrenaline, noradrenaline, dopamine, things we usually produce, but you just get a lot more of them. As we said, the amount of each catecholamine can depend on the tumour, and the pattern can be completely random. They can just sporadically release a lot. It doesn't do it in a sort of controlled fashion. A third of these tumours are associated with hereditary syndromes, so things like von Hippel-Lindau, multi-endocrine neoplasia type 2, neurofibromatosis type 1, and then there's something called paraganglioma syndromes as well. So when these tumours occur outside of the adrenal medulla, it's usually in these things called gangliomas or paragangliomas, which are part of the sympathetic nervous system. So you can get some syndromes that end up in pheochromocytomas, basically. So they can be malignant, can be cancerous, and I think it's about 10%. And they can lead to a lot of different acute presentations, which we're going to touch on briefly now. So can lead to cardiovascular complications, so things like a hypertensive crisis. So you might remember it's like one of those really rare causes of hypertension. Can cause shock as well, which I didn't fully understand, so I won't go into too much. Can cause arrhythmias, can cause MI, can also cause acute pulmonary edema, can cause things like bleeds and multi-organ failure as well, so it can make patients really ill. But I suppose hypertensive crisis is the main one that I generally think about with these. So we're not going to go into the presentation of each of these because we'll be here forever. So we'll go on to some of the investigations someone might do if a pheochromocytoma is suspected. So plasma metanephrines. So metanephrines, from what I understand, are just breakdown products of the catecholamines. So if the catecholamines are elevated, these will be elevated as well. And then you've got your urinary collection as well. So you do a 24-hour urinary collection assessing for metanephrines and catecholamines. And I think this is a bit more accurate than a random sort of blood sample. And that's because, as we mentioned, they can release these catecholamines in a really random sort of uncontrolled fashion. So that first step, sort of confirming that you've got a high level of catecholamines. The next thing you need to do is find out where this tumour is. So you know you've got something secreting lots of catecholamines, but you don't know where it is. So CT is usually used first. That'll detect about 90% of the cases. If that doesn't detect it, then you might move on to an MRI. And then, as we mentioned, these things can be quite hard to find because if they're not in the adrenal medulla, they can be anywhere from the neck down to the bottom of the pelvis, essentially. And you might do something called an MIBG scan. So my understanding is this sort of compound, MIBG, is similar to noradrenaline, but it's inactive. So they bind that to a radioactive isotope of iodine, inject it into the patient, and it'll basically move to wherever the tumour is and light it up like a torch or whatever. And then afterwards, you're going to consider things like histological analysis of these tumours once they've been hopefully operated on and removed, and things like genetic testing as well to see if there's an underlying hereditary cause. Cool. So we're going to touch on like some of the emergency management for pheochromocytomas. So as we mentioned, surgery is the main thing, the definitive management. So that's what's going to cure the patient. The surgery will cure 90% of patients with an identical pheochromocytoma on imaging. But as you can imagine, these patients aren't going to be suitable for surgery initially. The BP is going to be through the roof, most likely. So you're going to have to control the effects of these catecholamines first and stabilize the patient. So the main drug used in the acute phase is something called phentolamine, which is an alpha blocker. So it blocks the alpha adrenergic effect of these catecholamines. So that leads to vasodilation, and it's also in positive inotrope as well. So your blood vessels dilate, your blood pressure drops, but your heart function still works okay. And once that blood pressure is controlled, this usually starts something called phenoxybenzamine, and that's another alpha blocker, but it's given orally, I think. And it's got a long duration of action. So I think you have that phenoxybenzamine for a few days. I think it's at least 5 days. Don't quote me on that one, it might be longer. And then you can think about adding in a beta blocker. So that can be given to control any tachycardia and that beta adrenergic drive happening from these catecholamines. But it's really important you don't give the beta blocker before these. So if you give the beta blocker too early, you have nothing opposing that sort of alpha adrenergic effect of the catecholamine. So you get that vasoconstriction without the beta block, the beta adrenergic side sort of relaxing things a bit, if that makes sense. And then obviously you've got your general sort of supportive measures as well. So you're going to manage any arrhythmias, resuscitate the patient. You can also use calcium channel blockers as well, and managing any complications as well. So that's just a quick overview of pheochromocytomas. I didn't do too much on that one, unfortunately. Sorry about that, because it was just getting more confusing as I went into it. So that's the end of that. Thank you very much.